Thanks a lot, Honored Chairman. Ladies and gentlemen, dear colleagues, the previous speakers talked about thyroid cancer in detail, from diagnostic to surgery, and also pathological aspects of thyroid cancer. The next step after the surgery of good differentiated thyroid cancer, I mean papillary and follicular thyroid cancer, is normally performing a radioiodine ablation. Excuse me. As you know, thyroid cancer tends to be multifocal, and any remnants of thyroid gland could contain malignancy. And normal thyroid tissue has a significantly greater affinity for iodine than functioning thyroid carcinoma. And so detection and treatment of carcinoma are difficult as long as normal tissue is allowed to persist. The primary goals of a radioiodine ablation are first to destroy any remnant of normal thyroid tissue, second to destroy thyroid cancer cells, and also to identify distant metastasis by using whole body scintigraphy after the ablation. The rationale for radioiodine ablation is enabling achievement of negative diagnostic whole body scintigraphy, increases sensitivity and specificity of serum thyroglobulin as tumor marker, and as you know, the radioiodine ablation has just few side effects and reduces local recurrence rate, and also reduces mortality if tumor is bigger than 1.5 centimeter. Let me show you the results of this nice study published by Mazafari et al. 2001. They performed this study with 940 patients, and they had three groups of patients. After surgery, one group did not receive any suppression treatment with L-tyroxine. The other group just hormone treatment, and the third group radioiodine ablation followed by suppression therapy. And as you see here, the distant recurrence rate in this group, I mean the group which received both treatments, was significantly lower than other groups, I mean T4 alone and without any treatment. And it was also the case regarding all recurrences after thyroid surgery. As you see here, again, significantly lower recurrence rate in the patients who got radioiodine ablation followed by T4 treatment. If you take a look on Revised American Thyroid Association regarding radioiodine ablation, they recommend performing a radioiodine ablation for low-risk patients with a dose of 30 to 100 millicurie, and for high-risk patients with a dose 100 to 200 millicurie. But as you see here, between 300 millicurie and 100 millicurie, there's a very wide window, and you have to find the best dose for any patient. And in this table of American Thyroid Association, they classified the patients according T staging and N and M staging. But as you see here, regarding the effect of radioiodine ablation, here decreased risk of recurrence, conflicting data, and a lot of conflicting data. And also regarding radioiodine ablation, if it is recommended or not recommended, a lot of selective use. It is, I think this is not a real guideline. It is just confusing how we can manage our patients. And also it is the case for papillary microcarcinoma, PT1A tumors, the tumors with a size under 1 centimeter. From the American Thyroid Association, you read radioiodine ablation is not recommended for patients with unifocal cancer under 1 centimeter without other higher risk features. And radioiodine ablation is not recommended for patients with multifocal cancer when all foci are under 1 centimeter in the absence of other high-risk features. But as my previous speaker talked in detail about histopathology and different mutations, we know it's not easy to detect all of these risk factors. It's not easy for pathologists, it is costly, and we need experienced pathologists to find all of these mutations and also different histopathological aspects of a tumor. And the European Association of Nuclear Medicine recommend radioiodine ablation after total or near total thyroidectomy as a standard procedure. The only exception is patients with unifocal papillary thyroid carcinoma under 1 centimeter in diameter who lack evidence of metastasis, thyroid capsule invasion, history of radiation exposure, and unfavorable histology. Again, here also you see a difference between both of these recommendations. In European Association, they recommend they don't recommend radioiodine ablation just for solitary microcarcinoma, not for multifocal microcarcinomas. Different associations try to classify the patients regarding risks into low risk, intermediate risk, and high risk. Also in Germany, we have another classifications, and as you see here, intermediate risk from American Thyroid Association defined as microscopic invasion of tumor into the perithyroidal soft tissue at initial surgery, or the high-risk patients are patients with macroscopic tumor invasion, incomplete tumor resection. And regarding to this classification, they try to find the best way for preparing the patients for radioiodine ablation. But what is the extent of disease at presentation after surgery? We know about 36% of patients with papillary thyroid cancer has nodal lymph node metastasis, and about 13% of patients with follicular thyroid cancer have lymph node metastasis. And regarding distant metastasis, 4% of papillary thyroid cancer and 16% of follicular thyroid cancer patients. And also in patients who are clinically disease-free after initial presentation, they develop local recurrence, nodal metastasis, and also distant metastasis. Actually, in the last years, we have a lot of discussion, especially regarding low-risk group, how we have to ablate the thyroid, with which dose, with 30 millicurie as low dose, or with 100 millicurie, defined as high dose. Let me show you this review done by Hack-Show, published 2007. They did this review, they compared 30 millicurie with 100 millicurie, and they found the success rate of ablation in the high activity group, it means with 100 millicurie, was about 50 to 100%, compared to low activity group, which was 10 to 80%. And the pooled overall success rate with in high activity group was about 79%, and the low activity group was about 51%. But there are also, at the moment, two randomized prospective studies, which the results of them has been published. One of them is from France, written by Professor Schlumberger, and the other one was done in England, written by Professor Malik. In this in this study from France, they included 752 patients, a lot of them with papillary thyroid carcinoma, and all of them classified as low risk, or majority of them were low risk patients, PT1 and PT2 tumors. And they had 4 groups in this study. 2 groups. One group received 30 millicurie low dose, the other group 100 millicurie. And the other 2 groups, it means They have two groups regarding dose and two groups regarding recombinant TSH. And as you see here, the success of ablation was not significantly different between these groups. And therefore, they concluded that 30 millicurie could be enough for low-risk patients. And in other study, the British study, they had 438 patients. A majority of them were low-risk patients, but they included also PT3 tumors in this study. And exactly like the study from France, they had 4 groups of patients with low dose, high dose, and without or with recombinant TSH. And they found also no differences between the ablation success rates. But the question is how do we define the ablation success? First, there is no universal definition for ablation success, especially regarding thyroglobulin cutoff and post-ablation imaging. In these both studies, they use different criteria for defining the ablation success. The most important criteria were first the normal thyroglobulin level, and also the second one was unremarkable whole body scintigraphy 6 months after the radioiodine ablation. Let me show you this slide. In the estimable study, the study from France, they used the cutoff of 0.5% as for definition of the ablation success. And in the British study, they used a cutoff of 0.5%. But if you take a look on this scan, you see in this patient a slightly uptake. It's about 0.02%. It means the uptake rate, which used as a criteria in the both studies, in the France study, was about 25 times more than this uptake, which you see in this scan. 25 times more than this uptake, and in the HILO study was about 5 times more than this uptake. You can imagine how high was the uptake in these both studies, and defined as ablation success. And also the thyroglobulin level. In the study done by Schlumberger, about 43 patients had a thyroglobulin level before the radioiodine ablation. It was the case in 25% of the patients in the British study. It means a lot of patients prior to treatment had met one of the criteria which defined as a treatment success. And the other point from these studies, for example, from this study done by Malik, about 10% of the low-dose therapy group patients underwent a second radioiodine ablation versus just 4% in high-dose group. This difference was significant, and we have to know performing a second radioiodine ablation means treatment failure. Let me show you some other studies. First, this study done by Fallahi, published 2012. They compared also two groups of patients, 30 millicurie with 100 millicurie, regarding ablation success. I don't speak about outcome and other or progression-free survival, just we speak about ablation success. And they found in the high-dose group, the ablation success was 2 times more than the low-dose group, and the patients who received a low-dose radioiodine ablation with 30 millicurie, finally, cumulatively, they received more radioactivity compared to high-dose group because of the treatment failure. And also in this study, they compared three different doses with 30 millicurie, 60 millicurie, and 100 millicurie, and they found the rate of second ablation was about 2 times more than high-dose treatment, 22% versus 11%. In such cases, actually, we have to know what is the real-life condition in the world. First, how good can our surgeons operate the patients? In these both studies, they were randomized, controlled studies. They send the patients to the best surgeons who are experienced surgeons, thyroid surgeons. But a lot of patients in our routine are operated by ENT surgeons, general surgeons who perhaps don't have enough experience in thyroid surgery. It is a very important point. If you take a look on these results from the Hackshaw review, they normally we perform a radioiodine uptake test prior to radioiodine ablation, and they showed that in patients who had more than 5% uptake prior to radioiodine ablation, treatment with 100 millicurie was more successful than a treatment with low-dose radioiodine activity, and also in this study. Now, about the dose and dose calculation and dosimetry. It's a very nice study, a dose effect correlation for radioiodine ablation in differentiated thyroid cancer. They included 23 patients and they treated these patients with 80 millicurie. They excluded Hurter cell and aggressive variants of tumors. It means just papillary and follicular thyroid cancer without any aggressive variants. And they measured absorbed dose delivered to the remnant thyroid tissue, blood, and red marrow. The success, the ablation success achieved in 18 patients. A significant difference was seen between the absorbed doses delivered to thyroid remnants, blood, and red marrow for those patients who had a successful ablation compared to those with a failed ablation. And a successful ablation was strongly dependent on the absorbed dose to the thyroid remnant, which in this study was more than 50 gray. The most important point from this study is that they concluded some patients need more and some patients need less radioiodine activity for the ablation. Perhaps we need a dosimetry method. Perhaps we have to calculate the dose prior to radioiodine ablation, instead closing the eyes and say, okay, low risk 30 millicurie or high risk 200 millicurie. Maybe iodine PET CT will be an option for a dosimetry in near future. The next point is the follow-up. Follow-up is depend on patients, doctors, and guidelines. My colleague, Dr. Khalil, is going to talk about follow-up of these patients in detail, but I want to say the follow-up of patients is very important. If we do a radioiodine ablation with 30 millicurie, but we cannot follow these patients, it's very dangerous for our patients. In Germany, if you say a patient, okay, come in 6 months, they are in 6 months in your office. I don't know how is here or in other parts of the world. It's different. It's the mentality, and we have to take into consideration with which group of patients we work. As the previous speaker talked in detail about different gene mutations, I'd like also to show you the importance of BRAF and other gene mutations. The BRAF mutation is the most frequent genetic alteration in papillary thyroid carcinoma, and was demonstrated to be a poor prognostic factor. It correlates with multifocality, aggressive variant, and infiltration to the tumoral capsule, and it correlates with a persistent disease after 5 years of follow-up. And the presence of the BRAF mutation is also associated with a higher number of iodine-administered courses. It means we have to have enough knowledge prior to radioiodine ablation. And the question is, if we have all of this information prior to the radioiodine ablation, do we know which mutations are there? Do we know which type of histology? It's different in whole of the world. And also for papillary microcarcinoma, as you know, also in papillary microcarcinoma patients, about 25% to 30% of these patients show lymph node metastases. In this study, they define a system, a combined molecular pathological scores, which improves risk stratification of papillary thyroid microcarcinoma. They use different parameters: BRAF, superficial tumor location, intraglandular spread, multifocality, and fibrosis, and they tried to classify the patients regarding these factors to 3 different groups with a very good sensitivity of 96% and a specificity of 80%. It's a pathological paper, and therefore we need this information prior to performing the radioiodine ablation. Then we can decide for a low dose or high dose treatment. And also other factors like vascular invasion is also very important in papillary thyroid cancer. We did a retrospective study in our department with more than 300 patients, and we found exactly like TNM classification, the vascular invasion regarding outcome of patients is of importance. Let me summarize my talk. We have to perform a personalized medicine for our patients. We live in 2014, and everyone speaks about personalized treatment planning. We have to perform good operation. Total thyroidectomy should be done by experienced surgeons. We have to perform a dosimetry prior to radioiodine ablation, finding the best dose for our patients. The tumor stage is very important for decision making, but also tumor histopathology. Is there any aggressive variant? And other factors like angioinvasion and also different mutations should be known prior to radioiodine ablation. Then we can decide for a low dose, high dose, or for a very low risk patients, no radioiodine ablation. I have to mention here, we have a lot of good data with long follow-up, more than 30 years, which show us very good outcomes of radioiodine thyroid cancer patients after radioiodine treatment with 100 millicurie. But at the moment, we do 3 different things. We reduce the dose. We try to do the ablation under recombinant TSH, and also we reduce the L-thyroxine dose, T4 hormone, all of them together, but we don't know what can happen in 30 years. Therefore, we have to be careful. Thank you very much.